Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy.
Okay, so TMJ can get pretty complicated at times. Again, having your TMJ exam, all that good stuff automated in the beginning is going to help a lot. I'm interested to see how these three cases go, though. Do we want to jump into it?
Yeah. I think, am I up first for presenting, and then who's on the
I have
hot
to
seat?
enable screen sharing. There you go.
So Yakov is presenting first, and you're.
Oh, okay.
Yakov, you can share your screen and.
Awesome. Thank you. Let me just pull up the pull up my PowerPoint. All right. So I'm gonna play. I got some notes on a piece of paper, so you're not going to see any notes on the screen. And during the case, I'll try to kind of move you through it if I feel like you're getting the stuff really quick. This is about an 11-12 minute case, so it might end a little early.
Cool.
So your first patient is a 55-year-old woman who presents with what she calls long-standing TMD. She recently moved to the area, and she saw a surgeon somewhere else who performed an arthrocentesis and arthroscopy 15 years ago with resolution of the pain. She now reports difficulty and pain in opening her mouth. She's got left-sided facial pain throughout the day, and it's a little bit worse when she chews. So what's your next step? What would you like to do?
Obviously, I'd like to do a full past medical history, past surgical history, outside of the arthrocentesis you just mentioned, allergies, family history, all of that. Is there anything significant as far as those things go?
No, everything is unremarkable with the exception, like you mentioned, of her arthrocentesis, and she had an arthroscopy actually on the same side. So nothing significant.
Okay. All right. And then also just would kind of like ask more specific HPI questions, like any history of open lock, closed lock. I'd probably ask her if she could point with one finger to where her pain was. If there's any other things she's tried besides the arthroscopy and arthrocentesis for this TMD.
Yeah, she's tried some physical therapy. It's been a little bit helpful. She points with one finger right in front of the ear. She hasn't had open or closed lock. Okay.
Sounds good. So then I would do an exam on her. First, I would start with palpating extracapsularly, and then through the masseter, temporalis, kind of internally try to get some of that medial pterygoid. And then have her open and close, look at her MIO, protrusive, excursive movements. Then I would, let's see here. Then I would have her bite on something, both left and right side, see if that creates pain anywhere. And yeah, I think that would be my initial exam.
Sure. So she's got, that was exactly right. So she's got MIO of 25. She deflects to the left when she's opening. She has limited lateral excursions. She has over the left joint, very tender over the left joint. If she has an intracapsular process on the left side, on which side would she have to bite in order to feel pain in the left joint?
So left joint, it would be the right side. And so this sounds, and she doesn't have any pain in her muscles of mastication.
No muscle tenderness.
Yeah, so this sounds like a pretty straightforward as far as her diagnosis goes with an internal derangement. I would probably start with an MRI to confirm, and potentially, like if I had a cone beam in the office, I might get that as well, just to look at the osseous architecture of the joint as well.
Yeah, sure. So you send her for an MRI. In the meantime, you get notes from the prior surgeon. He said that the notes were sparse. He noted that she had left disc displacement with reduction, and she had mild synovitis and chondromalacia. What's the difference between synovitis and chondromalacia?
Synovitis is inflammation of the synovial cells of any joint. And then chondromalacia is where you see changes in the the articular surface, basically to like a less functional, why am I blanking on the word? The less functional joint. I don't know. I can't remember the word right now. Need to fully caffeinate before this. Go ahead.
So, so she comes back with the MRI, and so so you've explained chondral relation synovitis to her. She comes back with the MRI.
Yeah. So, it appears that, so in the closed position in picture A on the left, she has an anterior displaced disc. In the open position, that disc stays forward. So it appears that she has anterior displaced disc without reduction, and that's probably why she's unable to open further than 25 millimeters.
Sure. And what kind of MRI image is this, do you think?
So let's see here. I usually use the brain to tell. So we have, I'll just take a stab at it. I don't know, T1.
Yeah, I think so. I don't remember where in the feedback we can talk about it. I don't remember where I got it, but I think it's T1 too. Okay, so she's so she likes that you explain this to her. So what would you like to do next?
Yeah, so as far as this goes, I would say since she has an anterior displaced disc without reduction, it certainly would be worth opening her joint. In the meantime, I'd probably put her on like conservative treatment. But with that really limited opening to 25 and this disc that doesn't reduce, it's unlikely that conservative treatment is going to be particularly helpful, particularly after having arthrocentesis and an arthroscopy done already. So I would go ahead and get her scheduled for a disc repositioning procedure versus discectomy, depending on how the disc looks intraoperatively. And kind of talk to her about the risk benefits and alternatives of those things.
Interesting. Would you consider doing an arthrocentesis for her?
I mean, if she felt strongly about not having an open procedure, we could repeat the arthrocentesis and see if she gets some pain relief. But after having both of those done previously, I don't know, it's probably going to be a limited amount of time that she gets any relief. And I mean, it's not going to get that disc back into position unless you I don't do advanced arthroscopies where you can reposition the disc. And so, I would, if she really felt strongly about it, but I think that this disc needs to be repositioned in order to help this woman in the best way I can.
Sure. Okay. So you take her for the disc repositioning. Do you want any further imaging or studies?
No, I'm good with this MRI.
Okay. Did you get a CT scan for her, a CBCT in your office?
I mean, yeah, I asked for it.
Sure. So what features would you expect to see on the CBCT?
I mean, I'm guessing there'll probably be some remodeling since the disc is placed anteriorly, but outside of that, it would be hard to say without looking at her CBCT.
Okay, so she's in the pre-op area. What is part of your pre-op discussion for the repositioning?
Yeah, so talking about the risks, obviously the facial nerve is close to the area that we're working. There's very low chance of either having facial nerve complete paralysis or, more likely people just having some weakness after surgery. And then also discussing, when I open that area up, if the disc looks good, then we're going to reposition it. If the disc looks relatively non-functional, then we're going to remove it and do a fat graft to do an interpositional fat graft.
Okay. You take her to the OR. What do you tell the anesthesiologist?
Yes. So I would say that we can do oral intubation is fine, and tell them that the procedure might take up to 2 hours. And yeah, that's the long and the short of it.
Okay. Do you use a long-lasting paralytic?
Yeah, I would prefer longer paralytic for, especially when we're repositioning the disc. If the paralytic wears off and we're having trouble getting it moved posteriorly.
Describe your approach to the joint.
Yeah, so I like to do a preauricular approach with like a distal release. I stay very close to the external auditory meatus as to avoid the facial nerve. I'm going to do that through skin subcutaneous tissue down to the temporalis fascia. Once I get to the temporalis fascia, I make an oblique incision and then dissect down to the arch in a subperiosteal fashion. Then I'm going to open the joint with a T-shaped incision and take a look at where the disc is and inspect the disc itself and reposition the disc with a MyTech anchor and then close.
How have you avoided the facial nerve in your dissection?
Yes, so I avoid the facial nerve by staying close to the external auditory meatus. Studies have shown that it is 0.8 centimeters anterior to the EAC. So as long as you stay within that space, then as you dissect down, once you get down to the temporalis fascia and you're under the temporalis fascia, you've retracted the facial nerve anteriorly. And so at that point, you can dissect in that plane more anteriorly in a safe zone.
Okay. During you see that the disc is very ratty and has central erosion. You decide to remove the disc. You encounter bleeding medial to the condyle while you're surfacing the condylar head. So which vascular structure do you think could be responsible?
Most likely, it's probably the mesenteric. If it was like strong arterial bleeding, it could always be the internal maxillary, since that runs medial to the condyle. But yeah.
Okay. How do you control this bleeding?
First,
it's filling up the field, and it's just a little bit pulsatile. So what do you do?
Okay. So first, I'm going to pack the area. And wait for 5 minutes. I'll close the joint as well, because often that can like place some pressure in that area to tamponade whatever vessel may be bleeding. I'm also going to talk to anesthesia if they feel comfortable with giving the patient a little bit of hypertension. That's also helpful to whether or not that helps with the bleeding stopping. Then after 5 minutes, I'll like slowly remove that packing and have my electrocautery and some clips ready and attempt to identify the bleeder.
It's still bleeding. You can't identify.
If I've tried ad nauseum to stop the bleeding intraoperatively, there's always the option to contact an interventional radiology to embolize.
Sure. What do you tell them?
We have a bleeding vessel that is we're not able to identify. It appears probably to be retracted. It's likely the mesenteric or the internal maxillary, and we need to embolize it because I can't get control of the bleeding.
What path do they follow once they get arterial access? What path do they follow to get to the mesenteric artery?
Yeah, so it's going to be external carotid, and I think mesenteric's branch off of the internal maxillary. So internal carotid, maxillary, and then mesenteric.
Excellent. You gain control of the bleeding. The patient does well.
Okay, great.
That's the case. Thank you.
Oh, perfect.
I think it was like 13 minutes.
Yeah, that's good.
That was a good case. I thought that was pretty close to that's a very accurate case.
Oh, cool. Good. Great job.
Yeah, try not to go into unusual an unusual pathology.
I couldn't think of the word cartilage. I was like, oh my goodness.
Yeah, it's funny when you're in the hot seat, like thinking quick sometimes escapes you, and one word, will elude you for a while.
Yeah. My
In
dementia.
12 minutes, you only have a limited amount of time. Like you want to get past the initial stuff and get to the deeper stuff. Like if you're getting taken, if they're pushing you to call IR and what branches are leading you to the bleeder, you're probably in a pretty good spot. You're getting close to the end of the case. So that's a good sign.
Yeah, I'd run out of questions. I made at the end, sorry.
Yeah.
Oh no, that's great. We only have so much time. So
Yeah. Yakov, do you want to take us through it with any critiques or points you were?
Yeah, sure. I love the, I think you answered the questions very confidently. I could be wrong. I had a feeling that you're comfortable with TMJ pathology. That's why I skipped some parts of the case.
yeah.
I didn't ask for this, but I probably would have given her a Wilks. I thought your data gathering was appropriate. I probably would have given her a Wilks stage prior to
as far as a part of the diagnosis.
Yeah, I think so.
I don't think that's really, necessary, because even when you code them, you don't do like a Wilks staging, but I think that's definitely valid feedback. But yeah, so, because it's really like, is the disc out? Is there osseous changes? Like how limited are their opening? I don't know. I've always find Wilks staging kind of, anyway, but I can answer that question.
I agree. I agree. It's soft. I agree. It's soft. Maybe a soft question. And in my plan, for her, I had an arthrocentesis. Her last procedure was 15 years ago. So I think it could be reasonable to start to avoid an open joint in the meantime. And I just would have asked you about your technique. I would have asked about, I think some of the stuff, at least I saw on the written boards, were, the inflammatory factors that you're trying to wash out, the minimum volume that you're trying to use, technique, landmarks. I think that would have been part of my questioning, whether you inject anything. I don't know if you guys inject stuff into the joint, whether you inject anything.
That's a good question. Yeah.
It's not really, it's like controversial at best, I think. Some people say steroids.
I gotta sharpen my swords for the oral boards. I learned them from Patel, and he's the Lord. And I'm his protege, I'm gonna slay all these motherfucking questions today. Cause I got the sound bites, they're gonna make these old men go, ooh, ah, like some afternoon delight. I got these questions in my sight, and I got the answers. My answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.